Good afternoon from New York City. My name is Tom Maldonado. I'm a vascular surgeon at New York University Langone Health. I'm joined by my colleague, Michael Barfield, also a vascular surgeon at the same hospital. We're two of 9 vascular surgeons that cover New York University Medical Center. This includes Bellevue Hospital and the VA. We are really one of the epicenters, as many know, in the United States. New York City is that is, and we have a sort of a unfortunately, pretty robust experience as far as COVID positive patients. We have over 4,000 COVID positive patients we've seen since March 1 through early April. About a half of these were hospitalized, and about another half were discharged home. 14.6%, or roughly 292 patients, have died or were discharged to hospice. Of those who get put on ventilators, roughly a third die. So this is sort of a very grim picture, but there is some hope in that the curve, so to speak, is flattening. We're seeing just this week a very significant drop in ER COVID positive visits and hospital admissions. The patients on the vents remain quite significant number of ventilated patients of roughly 260 vents. We have nearly 180 or so that are on the vents, and these patients obviously have a poor prognosis. Many of them don't get off the vent, but that curve, that sort of mortality curve, and will eventually fall as well and flatten, I'm sure. So what we wanted to do today is really have sort of very easy conversational discussion between Mike Barfield, my partner, and I, and maybe cover some of these topics specific to vascular surgery and how we have handled the COVID crisis at NYU. So Mike, I'm going to introduce you now. Mike is a good friend of mine, a colleague. He is double boarded actually in not just vascular surgery, but critical care medicine. And I guess it's nice to finally recognize just how smart he is, since most of us in the vascular group don't have critical care training formally. So Mike, welcome. I want to obviously sort of give you some questions that we can then delve into a little bit more. So clearly, as vascular surgeons, we're used to seeing vascular emergencies and sometimes consults that are not so emergent. What are the types of cases you're getting called for as a vascular surgeon now? And what are the types of cases you're taking to the OR, or are there any?
So I think we're getting called for the most part. These are thrombotic complications. We've got a lot of DVTs, large DVTs. We're being asked to scan patients sometimes because the vascular lab is at diminished capacity right now. And IVC filter questions, whether a patient needs it or not, are certainly there. Almost all the patients who we've seen have already been anticoagulated just out of caution because of the rising Ddimer or something like that. So that's on the venous side. We don't participate actively in the PERT team here, but I do know, as we said earlier, the PERT responses, or sorry, the PERT activations have gone up. Yeah. On the arterial side, I've seen ischemic strokes. I've seen cold limbs. We've seen emboli going into the renals.
I think that the cases that I've seen that were taken to the operating room, though, really are the legs. Those are the ones that we're really having to, unfortunately, go to the operating room. And some of them we choose to anticoagulate because we find them prohibitively high risk. These patients who have, I mentioned earlier, a 30% mortality once you end up intubated in the ICU. Well, there is a whole line of patients lying prone who, a third of those are never going to leave the ICU. And some of those patients get called with a cold leg, and we choose to just anticoagulate. The ones that we have gone to the OR with are the ones that we maybe have not yet been intubated, that we feel have a better prognosis. And so those, I think, are the handful of patients that we're going to the operating room with.
Right. I think the other thing on the other side is the bleeding complications. We've seen some retroperitoneal hematomas. I've seen some intracranial hemorrhage just as a result of the anticoagulation. The good thing, I guess, about this process is that whenever you see some of these retroperitoneal hematomas, we haven't really had to have any of them intervened upon. They seem to tamponade or thrombose whenever you turn the anticoagulation off for a little while. Then the next question is, all right, when do we turn it back on? I haven't seen any of those patients with bleed yet who've then had a subsequent ischemic event, but I'm sure that's...
Well, we haven't taken anyone with a bleed to the operating room, that I'm sure.
Right.
So it's mostly thrombotic lower extremity events or sometimes upper extremity events that we've been called for. And then access complications, at the bedside sometimes. Most of those have been dealt with just manual compression, quite honestly. Not trips to the OR. We had one subclavian stent, I think I saw that we did for an access complication in the chest that we put a covered stent in. That may be the one.
I think we've seen that. We've seen, just tension pneumothoraces. So that's another thing vascular surgeons can do with putting in a chest tube if you feel comfortable with that. One of our other partners put in 2 chest tubes for tension pneumothoraces on his first day in the ICU because a lot of these lines are having to go in through subclavian access sites. And that's just not a line that's done as commonly anymore. So you've got people who aren't as comfortable with that particular technique probably doing it. And we're seeing those complications resurge.
Clearly, this crisis has impacted the workflow, right? We don't have the same, staff in the office. We've whittled it down to a skeleton crew of maybe 1 vascular lab tech, 1 doctor of the day who's there, and maybe 1 medical assistant. So we've gone from a staff of nearly 40 or 50 down to 3. We have 1 person taking call and a backup call person, and then we have those that are deployed to the wards. But then the real question also becomes, when do the ORs open up again? When do we start doing not just emergencies, but when do we start doing those urgent cases perhaps? We're not going to have a thriving varicose vein practice. That's not going to be the first thing to come back. And certainly the more elective surgeries, perhaps not also. But we're now in the phase, because the curve is flattening, where there's been discussion about getting some of those patients with the 6-centimeter aneurysms who were now delayed back on the schedule. That's kind of where we are at NYU now with these discussions. We're not there yet. We're still really restricted to the true emergent cases, but we are in those discussions. What do you think about some of the patients who you had to reschedule or canceled? Have you had complications, sort of this fallout?
So I was going to say, I know that I have not had any of my personal patients who've come into the emergency room with an urgent problem. I know that a couple of us in the group have had people with, cold legs. I think one of our partners did a bypass on somebody who occluded a stent. I did actually last night. I was on call yesterday. I had 3 emergency cases I had to do, 2 cold legs and 1 diabetic foot. One of the cold leg patients actually was a patient who was scheduled to see us for a first visit, who put it off because he was worried about coming to the hospital and potentially catching something.
Right.
And a very unfortunate situation last night. He had waited 10 days with a very bad disease.
Yeah.
So
And I had an aneurysm, again, not huge. It was a 6-centimeter aneurysm that came in. We had to cancel, but then came in last night with some pain. So this is sort of a secondary issue that is not directly related to COVID, but has some unintended consequence by canceling and rescheduling these patients. So it's something we're going to have to deal with, I think, as vascular surgeons going forward. Well, what about now that you have been on the wards, have been in the ICU? What are some of the common consults you're seeing as a vascular surgeon right now on these COVID patients?
So these patients tend to be very hypercoagulable. That was one of the first things I noticed whenever I started doing my ICU rounds. Was we were seeing patients who came in, and there's almost a point in time where if they're going to get bad, that bad turn comes with a huge cytokine surge. And I think that part of that is a massive pro-inflammatory and hypercoagulable response. As we have had patients coming in, we've been very proactive about getting a multitude of tests. And I think part of that is not exactly knowing what we were supposed to be following, but we've obtained a lot of clarity in that over the last few weeks. One of the first things I noticed as vascular goes was that we were seeing patients who were having Ddimers that were trickling along at 100, 200. And then as they would come into the ICU, those numbers would jump up to the 2,000, 3,000 mark. And if they were left to go for a day or two, it might be our labs internally only go up to 10,000 at NYU, and then you get a greater than 10,000. Bellevue, they actually, I think, go up to 50,000. And so they've seen the same thing there. We basically have seen these numbers getting in the tens of thousands on these patients. I know
What
that the
kind of
first.
vascular emergencies would you say that you are now taking to the operating room? Are there any vascular COVID positive patients you're taking? A cold leg, we get called all the time. A patient loses a pulse or the foot looks a little
Right.
dusky. Under normal circumstances, that patient might very much end up with an angiogram. How about now?
I think what we've seen, so there have been a number of arterial thrombosis cases that don't entirely make sense. We're not sure if it's an embolic phenomenon because some anecdotal data shows that they've got a propensity to form thrombus in the left heart. It could be embolic from that, but then we've also had patients who've had completely negative echoes and then they've presented with a cold leg that looked like there was an embolus. So we're basically handling these things based on the overall patient. Many times their pulmonary status is such that you cannot really safely take them to the operating room. And we have, in many cases, initiated anticoagulation. I know some patients on the floor with pulmonary emboli, for instance, have been given low-dose TPA directly through a central line. I know at one of the other hospitals in town, they have done some sort of systemic TPA treatment for these patients. And then we're absolutely anticoagulating people. I think as we've moved through this, we started being much more aggressive with our timing for anticoagulation. Typically, if patients are coming into the ICU, we're anticoagulating up front to prevent these kinds of complications as much as possible. Interestingly, as we've seen these arterial thromboses, I think we've only at NYU so far had one who we've actually taken to the operating room who was deemed stable enough to potentially have a survivable condition making it to the operating room. And that patient is actually doing well from everything I understand after going to the operating room. But we've had several others who we've just had to heparinize and be aggressive with that. And it's been mixed results with it, honestly.
One of the cases just from last night, if I'm understanding correctly, one of our partners had a embolectomy and went down and talked to a pathologist, and found some very curious results. They were very shocked at what that clot looked like, right?
Correct. The initially that was the one that we actually were able to do the thrombectomy on. Pathology actually called because they said they've never seen thrombus like this before. It was essentially 100% platelets, and then the platelet morphology wasn't like any other thromboembolism that they've ever really seen. So,
So do you think we should be giving antiplatelets more than just heparin or Lovenox?
it certainly begs that question. I think that there's certainly, I would say both at this point is kind of my bias on it. I think the anti-inflammatory properties of heparin will certainly tend to help that. I don't know that we've got a good picture of what the number of DVTs and PEs as far as the composition of that thrombus. It may be very different, but on the arterial side, where we've seen those complications, definitely leaning more towards at least aspirin in addition to aggressive anticoagulation with heparin.
So
Also had a couple of patients with HIT that we have been dealing with, and we, even despite the renal failure that we see in these patients, we've been using bivalirudin more than nargatroban in those cases, and the bivalirudin tends to do a little bit better as far as further prevention of DVTs.
Well, we have a number of trials, outcomes research. The IRB is being flooded with sort of protocols that have been submitted and fast tracked. And one of the ones that is in place now is to randomize people who have D-dimers greater than 2,000 to get full dose anticoagulation versus just prophylactic. But whether it's 2,000 or 1,000, there are some complications we've also seen from being a little bit generous with anticoagulation. As you know well, we've had some intracranial hemorrhages, some lung parenchymal bleeds. And so, there's no
hematoma as well. That was a big one that we had
right.
in my unit too.
Right. So, we are treating these patients aggressively with anticoagulation, but we're seeing some of the complications from that intervention, that treatment as well. So, Mike, as vascular surgeons, we obviously are accustomed to taking care of some of these patients with sort of advanced comorbidities, including COPD. So the ICUs is not a foreign place for us, but what do you think are the vascular surgeon's skill set that is best put to use when we're taking care of these patients?
Sure. I think that one of the biggest things that we do each day is ultrasound guided percutaneous access for the various vascular procedures. And so these patients are ICU patients. They need central lines, they need arterial lines, and really having somebody who can reliably obtain good access sterilely and does it routinely is key to minimizing the complications. And that's one thing that I know we've been able to offer routinely. We've had some of our cardiac anesthesiologists doing it as well, but I have certainly stepped in and done that, and I think a couple of my other colleagues have been doing that. Some hospitals are even having vascular surgeons do that as part of the team.
I mean, the vascular ultrasound for sure is something that we have a very active vascular lab. A lot of the techs are constantly in the ICU under regular circumstances. I think we've been a little less aggressive or less liberal with ordering those tests, and we use a lot of our own clinical acumen to just treat patients who we think are in fact positive for DVT without really insisting upon a duplex. But I think we do a lot of our own duplexes without having to call those techs in. So as vascular surgeons, we're very accustomed to doing ultrasounds in the operating room for access. And I think we can diagnose a femoral or a popliteal or even iliac vein DVT without needing a formal consult. I think that's been an important thing we offer as well.
Absolutely. And as you said, we've had about 2/3 of our lab staff out with COVID or with some other illness. So we've had to step up and do that. And we've really also trended towards, I asked them last week to do a policy where ICU attendings have to be the ones who authorize getting those studies right now, just to try to make sure that you're doing something not just algorithmically or reflexively, but making sure that it's something that's going to alter your clinical treatment. And so I think that's very important. We've put a couple of IVC filters into patients because they had really large DVTs and right heart strain on a point of care echo or something like that. And so when we go in,
there's also a fair amount of ECMO going on in access. I know some of our fellows have been, placing ProGlide devices in order to percutaneously close these sheets, which should they have to come out at the bedside, close the access point. So I think, again, some of these IV access procedures can be fairly large French devices as well when we talk about ECMO.
Yeah, and same thing. We have been in discussion with the different ICUs and talking with them about proper location for the different cannulas based on size and vessel characteristics and things like that. So we're actively involved in a lot of these discussions. I think another thing would be anticoagulation. We're very comfortable using heparin and using different anticoagulants all the time. And I was asked last week about, all right, we've got all these patients started on heparin. What's going to be the long-term plan for them? Nobody really knows right now. And so we're still involved in those discussions.
So clearly there's a lot of camaraderie that we have now given this crisis. We're all coming together, and sometimes we're working shoulder to shoulder with ophthalmologists maybe or orthopedic surgeons. And there's this kind of very bizarre, we're all kind of shoved together. And I think that actually can be very good and educational even. We're learning from each other. How does that affect the trainees, the vascular surgery trainees specifically?
Yeah, I think the trainees are certainly getting an appreciation for different things. I mean, it's been interesting where I know a couple of times they've talked about just sitting side by side with people who they would never normally be working beside. It's almost like you were an intern when you were in surgical internship working by ortho and neuro and all those. You have a very different conversation when you're a chief resident or a fellow sitting beside the same person and looking at a patient at what's going on. And so I think it's kind of expanding their thought processes beyond, just focused on taking care of what's right in front of them or whatever vascular issues may go. So I think that's very good. It's had many of them having to step up, like you were talking about, the ICU putting in cannulas and things like that for ECMO. They've had to go and kind of be the person there doing the ProGlide by themselves without having our eyes necessarily watching them, right in the operating room like it would normally be. So I'm glad they've gotten good at it. They've really shown that they've learned a lot, I think, from a lot of the things that we've done in the operating room with them. And I think that we've all had to learn a lot more, just kind of like we're doing here with the webinar. We've done a lot of video visits and video troubleshooting problems. So I think it's having them step into a little bit more of a responsibility role as far as being able to assess and accurately give us the information that we need. And then also, that it's been very good, I think, just with some of them and how they've got very different experiences through other places they may have trained or just having exposure to different types of technology where they've educated us on things.
Well, I mean, I think that I agree with all that. I think it's trying times for sure. A lot of the trainees look at OR case volume, and that's obviously the elephant
Right.
in the room, right? There's not as much surgery being done, but I agree with you wholeheartedly that there's a lot more to vascular surgery and medicine than doing a case, and I think they're getting a crash course in some of those things. Um, Going back a little bit to the hypercoagulable state, because I think that's something vascular. It's the common denominator, I think, to many of these patients who start to spiral and do poorly. What do you think? Do you think it's the D-dimer? Is there some interleukin, IL-6? Is there something that you see as the marker, or something that we can follow, and how we started to use that at NYU in treating these patients?
Yeah. So we get a panel that includes CPK, CRP, sed rate, IL-1, IL-2, IL-6, D-dimer, and probably another 5 or 6 that are all research related at this point, just because we've got many clinical trials going on at the same time. So I tend to get an overall picture of what the biological markers are doing. And they will generally trend up together or down together. The D-dimer tends to, I think, be a little independent, and so I'll look at that separately. And what I've seen generally is the ones who've got this D-dimer that goes like up to 1 to 2,000. It'll then tend to trend up again on day 2 to 7, 8, maybe 10,000. That's when we're starting to see what you were talking about, the PERT activations, or more of a tendency that makes us think they've got a DVT with leg swelling or something along those lines. And so we've pulled the trigger on aggressive anticoagulation when the D-dimer hits anywhere from 1 to 2,000. We do have a clinical trial that started now where we're doing full anticoagulation at 2,000, a D-dimer threshold of 2,000. I don't know if that's the right answer right now. I don't think any of us really know the right answer. What I can say is that I think that a lot of these patients are being hurt more with clotting than I've seen with bleeding complications.
So, we started talking a little bit about the NYU experience, and I mentioned there's a manuscript in press now that's going to talk a lot about our experience and some of our of the numbers of patients we've seen treated, released, the mortality rate. And one of the things that we're looking internally in NYU is some of the predictors of outcomes. And D-dimer is right up there as one of the top predictors, and 2,500 seems to be the threshold where you start to see poor outcomes once it reaches 2,500. The other predictors we should all mention, of course, are going to be age, greater than 75, but even the 65 to 75 range has been associated in this research. And then obesity. BMI is a big predictor of poor outcome. Interesting. What I'm mostly curious about really is why this gender gap between poor outcomes, and why males tend to do so much worse. I don't really have a good answer for that. I heard one study, not done at NYU, but we're trying to see what we can think about putting estrogen patches on some of these patients who come in, male patients, to see if there's something protective about estrogen. I think nobody really knows the answer to that, but it is interesting to see, and it does have some correlation, because in vascular disease, as we know, women tend to have poor outcomes at later ages. It tends to be affected. Men tend to be affected at earlier ages, and then women are protected, it seems, earlier on, and then catch up. So interesting, some of the common threads in vascular surgery between hypercoagulability and the risk factors we see, especially gender-related risk factors.
Certainly, I agree. And I mean, I think that some of the trials being right in the units where I'm working have been really interesting, looking at how we've tried to modulate all of the inflammatory mechanisms and try to do some sort of control over the hypercoagulable state that these people develop. I'll say that with the trial drugs that we've seen, I wait to see what the outcomes are going to be of the actual studies once they're published. But I think that one of the best things that we've been doing was starting this anticoagulation much earlier.
Well, let's wrap up with the last question, which I guess is sort of an open-ended, but what's the biggest lesson you've learned during this crisis, and how has it affected you?
I think the biggest thing has just been that you've got to be willing to be flexible and be willing to pick up and do whatever's needed to be done. If they need you to step up and be an ICU doctor, fine. If they needed me to take out the trash, I would do that. everybody has a role in this, and it may seem menial, or it may seem like it's completely removed from whatever your specialty and your skill set may be. But I assure you that if something needs to be done, the best thing to do is just pitch in, do whatever you can, and we'll all work together to help flatten the curve.
Very good, Mike. Well, stay safe. Thanks for today, for joining us here, and good luck. Talk to
You
you
guys
soon.
stay safe as well. Thank you for having me.
Bye-bye.